Hello everyone. Today I am going to be talking about gingivectomy. I am Dr. Vinita Boloor, a professor from Department of Periodontology, Yenepoya Dental College. Let us see what is this gingivectomy all about. Gingivectomy, as the name suggests, it means excision of the gingiva. The present technique which was developed was first described by Goldman in 1951. According to the World Workshop of Periodontics 1989, the gingivectomy is defined as an excision of the soft tissue wall of the periodontal pocket. In another term, that is a gingivoplasty, is basically just the reshaping of the gingiva to obtain a more physiologic contour, a contour that will allow a gradual rise of tissue interproximally and a fall on the labial and the lingual surfaces. This was also described by Goldman in 1951. The present technique of gingivectomy is described by the same author in the year 1951. What is the reason for doing this procedure? That is the rationale. Now, as we all know, the main treatment modality for periodontal therapy is to eliminate or reduce the pocket depth. So, the rationale was first put forth as pocket elimination so that we can easily access the root for instrumentation and also to create a local environment that the patient could maintain with daily home care. Let us see what are the indications and what are the contraindications for this procedure. First and foremost, it is to eliminate any suprabony pockets regardless of their depth if the pocket wall is firm and fibrous. Second is elimination of gingival enlargements. Another indication is to remove or eliminate any suprabony periodontal abscesses. Also to improve the soft tissue architecture, such as elimination of any soft tissue craters, irregular gingival margins and altered passive eruption. Exposure of the soft tissue margins of the restoration in case we need to access the subgingival areas so that the restorations can be done comfortably without any overhanging margins. Let us see what are the contraindications for this procedure. The need for bone surgery, or if any examination of the bone shape and morphology is required, we cannot do this procedure because we are not actually exposing the bone in this procedure. And in situations where the bottom of the pocket is apical to the mucogingival junction, because that would require that a lot of tissue is exposed or removed, thereby exposing the root surface, which will create future bone loss or future sensitivity to the tooth. In case of aesthetic areas, particularly in the anterior maxilla, this technique is not recommended unless it is required for crown lengthening procedure. And in case of highly inflamed tissues where the tissues are very soft, edematous, it is completely contraindicated because this inflammation should subside before we remove the gingiva. As we have already discussed in indication, it is only if it is firm and fibrous we are going to be doing this procedure. The inflamed tissues may respond just to non-surgical instrumentation alone, and definitely a surgical gingivectomy procedure may not even be indicated in such cases. In case if there is a high caries rate, if you are going to be exposing the root surface, there might be chances that there may be root caries in future. So, you have to see the caries level and also the oral hygiene level of the individual before doing this procedure, and if the patient or the subject will experience or they have high caries rate, it is not indicated to expose the root surface. Now, there are various techniques when we come to gingivectomy. There are various tools which also can be used for gingivectomy. So, let us discuss about this. Now, the gingivectomy techniques may be performed by means of scalpel, that is the blade, by laser, by electrodes or by chemicals. Although several methods are available, surgical is the most commonly recommended technique, and of late laser gingivectomy is also highly used because of its hemostatic properties. Now, let us see what are the instruments which we require in the surgical gingivectomy procedure. First and foremost, we need the probe so that we can probe the depth of the pocket. Second, we need to mark the pocket using a pocket marker. Then we need knives, periodontal knives, which are for gingivectomy, especially the Kirkland knife and the Auburn's interdental knife. And then these are the blade which are used normally, which is that is 11 and 12 number. And also 15 can be used for the same procedure.
Yes, sir.
As we can see, there is an enlargement between this canine and the premolar area. So this is an enlargement which requires excision because the tooth can be moved closer together. This is the second step where the pocket marking is done using the pocket marker. And once you get the bleeding points, these bleeding points will be connected by an incision. And this is an incision which is done using the BP blade number 15. And this is immediately after the procedure. As you can see, the enlarged gingiva from pre-op to post-op, it has been removed. And this is how the palatal aspect looks like after the procedure is complete. And this is 1 week post-operative, where you can see that the enlarged gingiva is completely eliminated, and also the orthodontic wire has been replaced so that the tissues and the tooth can be moved closer together. This is the palatal aspect of the same area 1 week post-operatively. The same procedure can also be performed with the laser. For that procedure, we need to first probe the gingival sulcus. As you can see, this is a periodontal probe which is marking the sulcus depth. Again, you can see that there is a pocket marking here which is done using a pocket marker. And the bleeding points are connected and the excision is done using a laser. This is immediately after the procedure. This was done for a crown lengthening procedure in the anterior aesthetic areas. And this is 1 week post-operative picture. As you can see, from the first to the last, there is quite a good healing which is seen after the laser therapy. Now, how does this healing occur after the surgical gingivectomy? We will see what are the steps which are involved. First, the epithelial healing stages, and then we will come to the connective tissue healing stages. In the epithelium, the exposed connective tissue is covered by a blood clot after gingivectomy, and within 12 to 13 hours, the wound is covered by a layer of polymorphonuclear neutrophils, which are the first layer of defense, and this constitutes a defense barrier which is also called as a polyband. After this, the underlying tissue becomes acutely inflamed because this inflammation is required for the inflammatory infiltrate to come in and develop in the connective tissue, and this inflammation is required actually for the primary healing. And after 12 to 24 hours, the epithelial cells from the margin of the wound will proliferate, separating it from the contaminated surface layer of the clot. The epithelial activity at the margins will reach its peak in the next 24 to 36 hours. Followed by 5 to 14 days, the surface epithelialization is generally complete and the normal epithelium thickens and it is restored. And during the first 4 weeks after gingivectomy, the keratinization is also less than it was before surgery, but the complete epithelial barrier takes about 1 month to develop. In the connective tissue, by 24 hours, there is an increase in the connective tissue cells. As I already mentioned before, there is inflammation. So, mainly the angioblasts, which are beneath the surface layer of inflammation, and necrosis will be seen. And in laser wound, the same set of stages are taking place, and it has been reported that the laser wounds heal more quickly and produce less scar tissue as compared to scalpel. Now, there is another procedure of gingivectomy using chemicals, that is called as chemosurgery, as I already mentioned, where they have used chemicals such as 5% paraformaldehyde or potassium hydroxide, which has been used in the past, but currently it is not used. I will come to what are the major disadvantages of this technique. One is you cannot control the depth of action, and the healthy attached tissue also which is underlying the pocket may be injured. Gingival remodeling cannot be accomplished effectively. Epithelialization and reformation of the junctional barrier occurs more slowly in chemically treated gingival wounds than in those produced by the scalpel. So, chemical technique of gingivectomy is no longer in use. Now, as we come to the end of this topic, let us see what are the things we need to consider before performing this procedure. One is, we have to conserve as much of keratinized gingiva as possible, minimal gingival tissue loss so as to maintain the aesthetics, and also we need to adequately access the osseous defects for a definitive defect correction. That means gingivectomy should not be performed if there is any osseous surgery or osseous corrections which need to be done, and we should see that there is minimal post surgical discomfort and bleeding by attempting surgical procedures that will allow healing by primary closure. Thank you.